I had a patient years ago who told me little bitty lady. It was so funny that she said it. She's like, I beat up my husband at night.
Wow.
And she didn't mean it in a mean way. She just meant
Oh.
that, her nightmares put
Mhm.
her in a state of fighting. And her
Wow.
husband, of course, sleeping in the same bed as her, you know,
Mhm.
he was the recipient of some of those and it blows.
Let's have a conversation about cognitive decline. Let's have a conversation about physical decline. We're educating masses about the brain and the spine. We're educating people about balance, gait, and decline. Let's have a neuro wellness conversation. Let's have a neuro wellness conversation. Let's have a neuro wellness conversation.
Welcome to Neuro Wellness Conversations, where clinical insight meets lived experience. We're two physical therapists having real conversations about neurologic wellness, nervous system health, and what it takes to support both in everyday life. And today we're talking about Parkinson's disease, not in the way it's usually discussed.
Right.
Because when most people hear Parkinson's, they think tremor.
Right.
But Parkinson's is so much more than that.
Absolutely.
So today we're going beyond the tremor and really thinking about what this condition really is, how it shows up, and why dignity, timing, and long-term support is much needed.
Absolutely.
So Dr. Lewis, this is your niche. Tell us
Yeah.
a little bit about Parkinson's and what you're doing at your clinic, like all that good stuff.
Yes, yes. So Parkinson's, I always educate my patients when they come into the office to understand that Parkinson's is a movement disorder. When you think about Parkinson's, you think about your movement being impaired.
Mhm.
But I like to educate them on the fact that it's beyond the movement that they have to think about.
Mhm.
And we get into the non-motor symptoms. And
Yeah.
so a lot of times I'll have them fill out the Parkinson's disease non-motor symptom scale. And
Mm.
when they do that, they realize that there are a lot more um, symptoms that they can relate to that are non-motor in
Mhm.
comparison to some of the motor symptoms. And so they have to think about it from a systemic perspective, is the way I like to tell them. And think about it as a whole body disorder,
Mhm.
whole brain disorder, not
Yes.
just a movement disorder.
That's it.
So they have to start thinking about some of those non-motor symptoms like issues with pain. We
Mhm.
have a lot of them that come in with shoulder pain. We
Mhm.
have quite a few of them that come in with back pain. We have quite a few of them that come in with issues of fatigue
Mhm.
or issues with sleep
Yes.
or mood changes and their thinking is foggy. There's GI issues, hypertensive issues, or hypotensive issues with some.
Oh yeah.
So those are all the non-motor symptoms. I had a patient one time, I gave him the non-motor scale and had him look at it while we were sitting there in treatment session. And I asked him, I said, yeah, what do you think? You have any questions or comments on it? And his thing was, this is really a lot of what I'm experiencing. And I was
Mhm.
like,
I believe.
yeah. I said, and I bet you didn't realize that a lot of that had to do with your Parkinson's. And
Mhm.
that's the thing with most of them. They never thought prior to coming in and getting this understanding that a lot of what they had sim- as far as their symptoms were being shown prior to diagnoses was relating to their diagnoses.
Yeah, no, that's a
Um,
real deal.
yeah,
So that was a great explanation of the non-symptoms because that is usually overlooked.
yes,
You know, the biggest one that hit that I always seen in the clinic was the cognition
yeah,
and not being able to dual task and or I should say do two things at once.
correct.
And that was a big one that I
Yeah,
always would automatically be like, okay, they definitely have Parkinson's.
Parkinson's.
There's
Yeah,
something going on here. There's
yeah,
something more
yeah.
than what they're telling us.
Right. And the multitasking is lost. And then when they try to do multiple things at the same time, their physical mobility is affected. So a lot
Mhm.
of my patients, if they try to do, say for instance, carry a cup of coffee and try to
Mhm.
ambulate at the same time, or carry 2 cups of coffee, which is even worse for some of them,
Right.
they end up with slowed gait, they end up with freezing of gait, fascination, and
Mhm.
so that's where that impaired multitasking tasking effect comes in, and then the cognitive effect of realizing that I have to focus on one thing at the same time is really, really significant and comes into play for them.
Yes,
Yeah,
it does.
cognitive changes are huge when it comes to
Mhm.
Parkinson's. Then you have, especially in that regard, the foggy thinking,
Oh yeah.
the inability to really um clearly process and sequence, and there's that delay in thinking sometimes.
Yes.
A-
Yes.
and the brain effect leads to a lot of times to fatigue.
Oh yeah.
And then there's also that issue with impaired sleeping, which I'm sure you've seen a lot of as well.
Whole lot. Unfortunately, that's one of the main things. People they always say that I'm exhausted.
Right.
I slept last night, but I'm still tired.
Yeah.
You sleep well last night?
Right.
Probably not.
Probably not. Quite. And then that's where the other issues that you have to kind of address. Okay,
Mm,
what's making you not sleep well? Are you having to get up because of urinary urgency or
yes.
urinary incontinence, which you'll see as well with a lot of the patients, and that's also technically considered a non-motor symptom. Or
Correct.
are you getting up because of pain? Are you
Mhm.
having cramping, in muscles, whether that be your legs or your backs, you know. And a lot of times the pain that I've seen, and you probably can attest to this, especially for my um patients with the unilateral presentation where they haven't been swinging that arm during gait.
Mm. Yep.
They come in with a lot of shoulder pain, and that shoulder
Yep.
pain is generally because that
Mhm.
arm is so immobile. And a lot
Yes.
of times they're holding that arm still because of the tremor. I've had some that way too. They're trying not to have it demonstrate itself too much. So they
Correct.
hold it close to them and they're holding it stiffly.
Mhm.
So that's another thing. So yeah, it's so much more than the tremor. Absolutely, Parkinson's
Absolutely.
is so much more than the tremor.
And that's where we come in with education. You know, when I when I normally work with patients, I literally have to sit down and figure out what their schedule is and figure out and pinpoint what they should be doing during the day.
Right.
Because and it's based on that medication schedule.
Yeah.
That's number
Absolutely.
one. You got to
Yeah.
make sure you're taking your medication on time and that you know when it's going to be effective 30 to 45 minutes after you take the medication.
Right.
You got to
Yeah.
plan around what you're eating, what time you're eating. So literally,
Huge.
I build out a whole schedule from when they wake up till they go to bed, and
Right.
it's life changing for some of them because they're like, "Wow, this is
Yeah.
really in depth."
Yeah.
Like I didn't think as deep as this because
As,
they're used to their normal routine, but it's like
right.
we got Parkinson's, and we got to deal with this so that you can stay as functional as possible.
As
You know?
possible, yeah. Then the other component to that, with as far as the medication, a lot of them don't realize that you also have to be cognizant of what you're eating,
Oh yeah,
when you're taking your medication. The timing of your medication is important. And I found myself educating a lot of them about the fact that protein can interfere with, their dopamine, their
Yeah.
carbidopa levodopa, absorption. And a lot of them were like, wow, I never knew that. And, the doctor didn't tell me that. And
Yeah.
so, like
Yeah.
you said, the educational component is huge,
Mhm.
huge, huge, huge. And I think that's what makes us stand out, as neuro PTs,
Mhm.
but as also practitioners that have our own clinics. You know,
Yes.
we've seen the need for it, and we have the opportunity to it, and hence why we have the success that what we do with our patients. And I'm so glad that I have the opportunity to do it, because it's such a big necessity with the Parkinson's population. One of
Huge.
the things I used to do is my first visit, I created an ebook, and then anybody that goes on to my website, pauletteLewisDPT.com, they can get access to that ebook for free.
Nice.
And that ebook kind of lists some of these things that we're talking about, but it gives them that educational component that a lot of times it's an eye opener for them, because
Mhm.
it's like, wow, I never knew this. I never knew that. Because, so much of the movement side is emphasized and
Mhm.
discussed, and um we talk about the five, main symptoms that lead to diagnoses, but what they fail to emphasize a lot of times, and what people that have Parkinson's that I found fail to really understand significantly, is the non-motor symptoms,
Mhm.
which we're discussing today. And that's, I found that it's so important to educate them about that. Yes, it's important to, to discuss, talking about balance and gait, and,
Oh, yeah.
the tremor, and, the rigidity and the bradykinesia. That's, postural instability, all of that stuff.
Mhm.
But when somebody is not sleeping, when
Mhm.
somebody's having nightmares and night
Yeah,
terror,
that's a big one.
yeah. I had a patient years ago who told me, little bitty lady. It was so funny that she said it. She's like, I beat up my husband at night.
Wow.
And she didn't mean it in a mean way. She just meant
Oh.
that, her nightmares put
Mhm.
her in a state of fighting. And her
Wow.
husband, of course, sleeping in the same bed as her, you know,
Mhm.
he was the recipient of some of those and it blows.
My goodness. But this is
But real life, and so we had to have a discussion on that, and then I had to tell her, make sure you definitely discuss that with your doctor, because that's going to require medication change possibly, or
yeah.
dosage change possibly. So something that needed to be done, and even maybe the discussion of sleeping in two separate beds may have to happen.
Yeah.
So there's a complexity to
Yes.
Parkinson's that I think a lot of people don't realize and understand.
No, another big one is blood pressure changes,
That's
causing dizziness and, you know,
yeah,
they're
yeah,
they feel fine and then all of a sudden they're lightheaded,
yeah,
blood pressure
yeah,
drops.
right.
So that's a whole nother thing. And
Yeah,
that it's life changing again. Like
life
these
changing.
clients, they're
And
normal, they're going out, and then all of a sudden,
yeah, they stand up, and then next thing you know, they're dizzy and woozy, and falling in some instances, once they get up and take a few steps. Yeah, the hypotension is also significant, because a lot of them have the symptoms but don't understand that
Mhm.
it's relative to the Parkinson's. Because
Correct.
we when we think about dizziness and lightheadedness, a lot of times it's so cardiovascularly related that
Correct.
we think about having to go to the heart doctor. Oh, I need to go
Mhm.
to the heart doctor first. And then we don't think about the fact that, okay, yes, I still need to go to the heart doctor and check things out. But I also need to understand that this can be relative to the Parkinson's.
Parkinson's.
So if it is, and that's one of the reasons why in our clinic we take blood pressure with everybody that comes through the door.
Absolutely.
everybody that comes through the door gets their blood pressure checked at the
Mm-hmm.
beginning of the session, sometimes throughout the session, post session. And
Mm-hmm.
so monitoring this for these patients, especially when they come in and it's low and they're,
Right.
whoa, that's, your blood pressure is 80 something over 50 something, and
Mm-hmm.
you're coming in and dizzy and staggering, that can explain it.
Absolutely.
And if we weren't taking blood pressure, they wouldn't know that.
Wouldn't even know. They
Wouldn't
have
even. So
no idea.
no idea. And so understanding what is happening in that regard, knowing how to address it, there's different recommendations that can be made. Medication may have to be involved in some instances, making sure there's hydration going on with the
Big one.
because Parkinson's patients, because of the urinary issues,
Mm-hmm.
don't want to drink water.
That is true. Yeah. I've come across that quite a bit.
Oh,
Yeah.
yeah. They don't want to drink water because they're afraid that they're going to have to go to the bathroom. This is a conversation I have frequently with my patients because we see so many Parkinson's patients at our clinic. And so I'm constantly telling them you cannot not drink water because it's the effects of dehydration. It can be even worse than what you can ever imagine. In some instances, probably worse than some of the symptoms that they're experiencing at that particular time with regard to the Parkinson's. So, yeah, hydrating. Another thing we do at our clinic, making sure our patients are hydrated. We provide water for them throughout the sessions. Encourage them to bring their own, because some of them will always make the excuse of, oh, no, I drank some in the car, or my water bottle's in the car, that kind of thing. And we're like, no, you need to bring your water bottle in you. And then I've had to have the conversation with one of my patients, actually this past week, because what I realized, he came in on one of his days that he didn't really feel his best. And so when I see the change, I'm always trying to, my research brain is always trying to get to the bottom of what's really going on. And for one, he had a piece of fruit and a little fig bar for the day.
Oh no.
This was late afternoon by the time I saw him. And he had consumed very little water. And so, and his case is not isolated because I've seen other patients that have come in and they've had little to no water and their symptoms are exacerbated. And they have their bradykinesia is even worse. They just don't feel well. And I always educate them about dehydration and the effects of it. So yeah, hypotension, huge.
Big one. Big
Yeah.
one. The other
And
thing. No, go ahead, finish.
no, I was gonna say, and one of the things too is educating the caregiver
Yes.
on a lot of these things is huge as well.
Yes. So they need to know what symptoms, motor and non-motor,
Right.
for and know what to do. You know what I mean?
Know what to do. Yeah.
But as for as clinicians, I'm big into staging. So I'll do my evaluation and I'll say, okay, you're probably a stage 2 or stage 3 Parkinson's.
Mm-hmm.
And a lot of these clients, their neurologist has never talked to them about the different stages of Parkinson's. So they're like, nobody's ever said I was a stage 1 or a stage 2. But it's good for us to be able to educate our clients on that so that the goal is to maintain them where they are.
That's right.
And then
I tell them that. Yeah. I tell my Parkinson's patients that too, because I use the modified Hoehn-Yahr staging scale with them, and then I'll explain to them what it is. And there are some that want to perseverate on it a little bit, and I have to kind of talk them off the ledge a little bit and say, look, we're not going focus on this. We're gonna work, and we're gonna work on trying to be the best you that you can be. And so that kind of takes them away from that. But yeah, staging is huge. And like you said, there are many that have come through the door who never heard about the staging, other than um, maybe hearing a a symposium or a speaker of some sort, or reading something that talked about it, but I don't think they really fully understood it. Um,
Right.
and so it's so important for us to do that, and make it
Yeah.
a part of our objective information that we keep, because
Mhm.
I use it to help them be motivated,
That's
especially
it.
for those that need that, because that's also an poor motivation is also a non-motor symptom.
Yes,
Um,
it is.
yeah, and I give them something to think about and work towards. Okay, this is where we are today, but this does not have to be where you stay, you
That's
know.
it.
And it's
That's
so
it.
important, especially even for our young onset. Our
Mm.
young onset population probably doesn't get as much attention as
Um,
the older population, I would say. How do you feel about that?
yeah, they definitely don't get enough attention because you know why? They look great. They look fine on the outside. They're
Yeah,
functioning, they're high functioning, they're grocery shopping, they're working.
yep,
So, yeah, they don't get the attention, but the young onset should come see us. Even if
absolutely.
they're doing completely fine so that we can stage them, tell them what they need to continue to do to maintain where they are.
Right.
And if something goes awry, then you come back in.
Exactly.
But
Exactly.
that doesn't seem to happen.
No, it doesn't. And I think a lot of it has to do with the fact that they are more mobile. They're
Mhm.
still, like you said, they're still working, they're still functioning, and they don't feel like they need that extra assistance.
Correct.
Um, but what the research is showing is that they need just as much education, if
Yes.
not more, so that
Yes.
they understand that this is what you need to do. I remember one of my first young onset clients was a nurse, had
Mm.
a young son. He was I think he was probably early middle school age, and her biggest thing was she used to do phlebotomy sticks,
Mhm.
and but when she walked, her gait was almost ataxic. But when she
Wow.
did her sticks, she was steady as a rock. But what I did with her was I taught her exercises that she could use at home, put
Mhm.
that HEP together for her. But I provided her with a lot of education so that she understood her body
Right.
and could recognize any changes that she started to have, so that
Mhm.
she would know what to do next. Because they are the kind of patient that probably won't want to be in therapy for very long because they feel like they don't really need it.
Yeah, I mean, I personally, I might see them for a couple of visits and then I'll kind of say, okay, I'll see you in 90 days.
Right.
Unless something else pops up before then, come back in. But at that point, like you said, it's more just education
Just
and saying, okay,
education.
you're at stage one, you're doing great. This is what I want you to work on. Continue your high level activities,
Yep.
do some strength training at the gym, that type of thing. But if you notice these symptoms,
Yeah.
back in because that's telling us that you're progressing a little bit and we may need
Right.
to do further treatment.
Yeah.
So I typically don't keep them on. I might see it for a couple of sessions and then I said, all right, I'll see you in 90 days or sometimes a little bit longer depending on how they're doing.
Yeah, yeah. Yeah, no, they don't have to stay on for very long, but I
Oh,
think sometimes they wanna come in, do an eval, and then be discharged
oh yeah, yeah, yeah. They do. But
after
I
that. So, I'm like, "Okay, no, let's make sure you understand your exercises. Let's make sure you've got a plan of action, because a lot of times they're sink or swim,
oh yeah.
out there in the world of Parkinson's. And so it's good to see like the Parkinson's Foundation kind of spending a lot more education in that group, because for a
Yeah.
while they were really not getting the attention, especially when it came to research as well. One of
Mhm.
my earlier clients, young onset gentleman, I met probably about 9 years ago. He came to the clinic, and very fit guy. Used to work up pretty regularly. When you see him walk, you probably would not have really noticed
Mhm.
that he did have a mild Parkinson's walk. If you were not trained to see certain things and observe certain things, and he actually was it, out of the country visiting some family,
Mhm.
went to see a friend to kind of work with him and stretch him. And it was that friend that noticed the deficit in the shoulder
Mm.
as far as the range of motion, but also noticed a mild tremor. And he suggested that when he
Wow.
came back to the United States, that he see a neurologist.
Mhm.
And that's how he discovered he had Parkinson's.
Interesting.
Yeah. So when he came to me, he didn't even realize that there was a discrepancy in the range of motion of his shoulder,
Mhm.
and that there was because this was a gym guy. He worked out,
Mhm.
almost every day. Um, but when I assessed him, when I measured his range of motion in comparison to his opposite side, and it was his dominant side
Oh boy.
that had the effect. When I put him on the treadmill and had him walk
Mhm.
at different speeds, recorded it,
Mhm.
showed it to him. That's when he noticed, wow, and, never realized that he was
Yeah.
displaying these symptoms. So we put a plan of action together. I run into him every now and again, still at the gym,
Mhm.
still
Nice.
still working out, and to this day, he thanks me every time he sees me because
I love that.
he's like, if it wasn't for you, I wouldn't have the understanding that I have. And
Mhm.
you know, he probably would not have been as mobile as he is to this day.
Right.
So yeah, it takes somebody with the knowledge and the eye,
That's a
and
big one.
yeah, and then knowing
Absolutely.
what to do with what you're seeing,
Absolutely. Being creative with it,
being very creative.
you know.
In
Being
some instances, I've had some that went to other therapists, unfortunately, who didn't really know how to
Mhm.
treat Parkinson's. And it's more than just, and then this is what I tell my patients. I said it's more than just giving you exercise.
Correct. Very intentional.
Very intentional, and I'm sure for you, you have seen the same thing in your dealings with your Parkinson's patients.
Absolutely. I mean, I've had other clinics call because they were like, we have Parkinson's patients and we don't really treat that here. But I have had patients that went to a sports medicine or ortho clinic and they just got the same regular exercises as everybody else and
That's
they
right.
didn't see a difference.
Yep.
And again, when you go to a neuro clinic like ours,
Yeah.
the education is key.
Key.
I need
Huge.
to know what's what stage you're in, how you're performing,
Yeah.
those non-motor skills,
Yep.
those non-motor symptoms
Symptoms.
that
Yep.
we're looking at. All of that comes out, and they're like, nobody's had this discussion with me before.
Yeah, yeah. And another big thing for me with my patients is your function.
Yes.
What is what is your goal? What are you unable to do?
Mm-hmm.
How is this disease affecting you functionally at this present
Correct.
time? And
Yes.
so our goal is to get you back to that functional level, that where you feel like you are not a lesser person because of the Parkinson's disease.
Absolutely.
And so I check on my patients even after discharge.
Oh yeah.
I and then we have our transitional program where
Mm-hmm.
we transition them into a maintenance program of some sort, and we've been fortunate to have gotten the Parkinson's Foundation grant
Nice.
over a year ago that extended our boxing program for our Parkinson's. I call them champions because
Yes,
they
they are.
yes, they are. So that's the other thing where it allows me and it affords me the opportunity to just, you know, stay on top of some of them with
Yes.
regard to their symptom and symptom progression, and they love it. You know, they love that there's somebody who has the eye because I
Yes.
can, you know, spot some things with them before they even tell me.
Yeah, that's real. And
But
boxing is fun.
boxing is,
You
they
know,
love it.
there's
You know,
strategy behind it, but it really is fun. It
it
works
is.
their mind and body
Yeah,
together. You
yeah,
know, that cognition is important. Are they able to follow directions? Are they able to
right.
do that two tasks at once?
Yeah,
Maintain
yeah,
their balance. It's
yep.
really cool.
It is cool, and you get to integrate all of these things that challenge them and help them work on those things, you know, and to create that neuroplasticity that we always talk about,
Yes.
you know, because that's what it's all about for them as far as their programs and their home exercises and the things that we do with them. It's all about getting that brain change, is what I tell them.
I love that. Brain
Yeah,
change.
brain change. So Parkinson's disease, yes, is far beyond the tremor. Far, far, far beyond the tremor. And it's important that we address the multi facets of
Mm,
the disease and the diagnoses so that our patients can benefit from, you know, all that we have to offer and all that we have in these brains of ours that God blessed us to have.
yes, and I want our listeners to know, if you know anybody with Parkinson's, or even if you have Parkinson's, to make sure you seek a neuro specialty physical therapist that's going
Absolutely.
to understand what's going on with you and what help you're going to need and get you in the right direction
That's
in
right.
regards to keeping your function.
Absolutely. Absolutely. And I 100% agree with that, because, you know, your neurotherapist is going to have a passion beyond what you could even imagine. And so that's for your benefit. Take advantage of it. And for those that know anyone that has Parkinson's, share this episode with them, you know, so that if there's any questions, they can reach out to us. We'll definitely try to help them in any regard and help find someone that they can kind of relate to if need be.
Absolutely. So I want to close out with so if there's like one thing that I want you to take away from this episode, is that Parkinson's is not just a movement disorder, it's a whole person experience.
Absolutely.
And when we start to recognize that, we can move from simply managing symptoms to truly, truly supporting quality of life, dignity, and long term function.
That's right. That's right. That's what it's all about. Thank you
Absolutely.
all for your attention.
Until next time.
Until next time. Thank you for listening to Neuro Wellness Conversations, where clinical insight meets lived experience. If today's conversation resonated with you, share this episode with someone who could benefit. Be sure to subscribe so you don't miss future conversations on neurologic wellness and nervous system health. Until next time, keep supporting the nervous system that supports you.
Let's have a conversation about cognitive decline. Let's have a